Okay, hi everyone. Thank you so much for joining our webinar today, where we will be talking about the opioid epidemic and what employers need to know. This webinar is brought to you by Orange Tree Employment Screening, and the presentation will be given by Nina French, Managing Partner of the Current Consulting Group. Nina has been a longstanding member of the employee screening community, advising clients on drug testing strategy and occupational health and wellness operations. After the presentation, Nina will definitely be available to answer any questions you might have and to continue the conversation. If you have a question, please raise your hand through GoToWebinar, and we will be sure to unmute you to ask your question. Thank you so much for joining us, Nina.
Thank you. Thank you for having me, and welcome, everyone. Good afternoon or good morning, I guess, depending on what coast you are on. Today we're going to talk about the issue of drugs in the workplace, but not just drugs. Specifically, we're going to talk about prescription drug use and the epidemic, not only in the workplace, but that's happening in the United States today. In drug testing and in screening in general, there is and always has been a distinction between legal and illegal drugs. When you look at the panel that you test for in your drug testing program, it's important to note that most of the drugs in that panel can be legally prescribed in the United States. There are some exceptions. Heroin is one. Marijuana is one with some caveats. We're going to talk about that. PCP is another. PCP cannot be legally prescribed in the United States. And so there are some that cannot be legally prescribed, but many of them can be legally prescribed. And you would really have to have shut off your TV and gone off of the web to have not heard or understood that we as a country have an epidemic in the United States. Very specifically, one of the issues is opioids. Over 2 million Americans are estimated to have a problem with the opioids right now. I'm going to pause for a second and say, what is the difference, right? Now, we used to always hear the term opiates, and now we hear the term opioids. Opioids is a broader definition of opiates. So it includes all the drugs you used to think of, morphine and codeine, right? But now it is opioids so that it can include that class of drugs that are synthetically created opiates. So they are not created from the poppy plant, but they are derivatives of drugs that mirror or match or are similar in their use to opiates. You need to pause and sort of think about how this has come about in the United States and how significant it is. And we're going to a lot of stats in today's presentation that I'm not going to read, but what I am going to do is go over them in general so you can understand the extent of this problem. And I think what the most important thing is, you have to understand not just the extent of the problem, but that it is impacting your workforce. If you think it's not, then it's, again, the idea of shutting off your TV and going to bed and not paying attention to it. Because according to the latest survey data, over 97 million people took prescription painkillers, and that was in 2015. So that was like as this was starting to come to a head and people were realizing the extent of the addiction issue in the U.S. and the abuse issue. 12 million of those 97 million did so without being directed by a doctor. And so, you can't raise your hand today except if you're asking a question. But if you think about your medicine chest at home, I want each of you to think about how many drugs do you have that are left over from an operation, from a broken bone, from a tooth extraction, and are any of those opioids? And the chances are yes. And so think about how this came about. And really it came about with the era of the HMO, right, and PPOs and doctors having a set amount of time for visits and a set amount of visits for which they could see someone in a year. And so we had these two things sort of coming together at the same time. We had the availability and use of some of these opioids that are, I want everybody to be aware, at they have medicinal purpose. If they didn't have medicinal purpose, they would not be on the market. And as we talk today, we're going to hear about an interesting story about how this is changing. But these are drugs that you know, right? These are Tylenol with codeine. These are Percocet. Those are the types of drugs we're talking about. Many of you have been prescribed them because of an illness or an injury. And so what happened is doctors would see patients, and often because the patients were not allowed through their insurance company or just through their lifestyle, we're not going to come back, or the doctors didn't have availability for them. They were prescribed a longer prescription, right? So they were given a 30-day prescription with 2 refills, take as necessary. And so that isn't the full fault of it, but it was sort of that time frame where we started to see medicine and addiction to prescription medicine increase in the country. And the jumps are so significant. So as you look at what consumers have spent in, the years between 1960 and 2005, we went from prescription drug spending from $2.7 billion to $200.7 billion. And again, 2005, the significant jump from that to 2015 is alarming. So total spending on prescription drugs in the U.S. rose to nearly $425 billion in 2015. So you could see how big and how quickly this problem grew. And again, it's that non-medical use. It's second now only to marijuana use in the nation. And so where we saw variety, we would see a lot of marijuana, and then we'd see a lot of marijuana cocaine. Now we see a lot more of the prescription drug use without a prescription. And so now that treatment providers are starting to understand the signs and symptoms, recognizing how extensive the problem is, we are starting to see where companies, employers, healthcare administrations are starting to look for the signs and symptoms and come up with drug testing methods that deter the use. But it is not as simple as what we've seen with sort of that standard 5-drug panel. And so we're going to talk about that and how you deal with prescription drug use and how it's a little bit different, and how, as an employer, you can have an effective program that both detects and deters the use of prescription drug use. So we talked a little bit about what opioids are and why we changed the name, right, from opiates to opioids. But let's talk about what they are. And they're drugs that act on the central nervous system to relieve pain. The issue with them is they are extremely effective in that, right, the relief of pain, extremely effective in that. And there are lots of variations of them, right? So we talked today and I'm not a doctor, right, but we talked about hydrocodone or Tylenol with hydrocodone or Percocet. You guys know the other names, right? There are things like fentanyl. There's things like Oxycontin, oxymorphone. And so the derivatives and the different variations of these drugs are used very differently in the medical community. They know when you should be prescribing the acetaminophen, which is Tylenol, with codeine, or you should be prescribing something different like an oxycodone. So there are different times and treatments that it's appropriate. However, across the board, be it an opioid synthetic or an opiate, they do lead to physical dependence. They do lead to withdrawal symptoms. They come in a bunch of different forms, right, including patches, tablets, capsules, liquids. The short-term effects are pain relief, right? We're going to say that. That's the first and foremost. Drowsiness, sedation, feeling of euphoria can all come from it. But their main purpose is pain relief when they are prescribed. So opium is a narcotic, and it's made from poppy. And so you guys can think back probably and remember stories about Afghanistan and poppy fields, and they're grown all over the world. But they've been here forever. When you think back and you think about reading books about ancient Chinese culture, there were opium dens, right? These have been around for a very long time. So opium first came from from that we started to get other drugs like morphine, then heroin. So make no mistake, heroin is an opiate. It is an opiate that has no medicinal value in the United States. So what you've got to remember is when you think about things like heroin, heroin isn't devoid of that pain relieving attribute. What it's devoid of is what the issue with opiate is. It was determined that heroin, the bad outweighed the good, right? So everyone here has heard how addictive it is. It hasn't been produced for that pain relieving sensation, and therefore it's a Schedule I drug and can't be prescribed in the United States. That said, it is an opioid, right? It's derived from opium. So now you see those prescription drugs like Vicodin, Percocet, OxyContin. They are the derivatives that are collectively known as opiates. They act very similar to what we saw that was derived from the plant, but they're different. And now these synthetic drugs like methadone and fentanyl are grouped together into this whole big category. Fentanyl is one I'm sure you're hearing about recently. But we're going to talk a little bit more about what we see and where that's hitting the market and how it's impacting people. But what we know is that they regulate pain and they give a sense of reward. And again, you've heard stories about people who really say as a heroin user they were hooked from the very beginning, from that very first use. So they're very powerful, but they're extraordinarily addictive in most cases. And again, you've likely heard someone say they know of somebody who started taking a prescribed opioid and was addicted very quickly. And so we know that people are using. We also know that this isn't something historical. So a 2016 SAMHSA survey on drug use showed that 6.4 million people reported misusing these drugs in the past month. And 3.8 of those people were misusers of prescription drugs. So this includes all of them. And when we talk about current users, we're talking about 30 days, right? So this isn't somebody who said, yeah, I used it once, I haven't used it again. The misuse trend is very recent. So 30 days is what that information tells us. We also know that young adults are at the center of it. However, this is not a problem that is exclusive to a young community. Young adults aged 18 to 25, so the workforce that is coming towards you, your summer hire, your temp labor in general, that is one where we're seeing the center of the increase. And so we see a continued increase over the years of drug use among that category of person. It's a big part of the problem, the prescription drug use. So when you look at this slide, this is age 12 or older. And it is important to note that 12 and older is not insignificant, right? Look at the different categories, but 18 to 25 is where we see the largest percentage of use in the past months. But you also see significant use as the employee or the person gets older. So it's significant, it's across the board. And so again, I want you to look at these slides and look at your makeup in your workforce. So if these are the age groups, right, which they are, 12 and older generally, that you are prescribing, in this slide we're seeing age 20 and over. This is the prescription opioid use in the past 30 months, or in the past 30 days. And so, again, apply this statistic, and this is a little bit old. This is 2012, we end this data, so we're already 5 years out from that. You'll see that 6.9% of adults aged 20 and over in the United States have taken or misused prescription drugs in the past 30 days. So think about your workforce and do the application and know that that is generally a trend that you're seeing in your workforce, whether you're recognizing it as well. And so as the prescription drug sales quadrupled from 1999 to 2014, we haven't seen an overall change in the amount of pain Americans report. So again, this is where we're starting to see the drug use has gone up, so that might have been the trends in how it was prescribed. But we also are seeing people who are doctor shopping and who are starting to get into abusive scenarios with these drugs. 1 in 5 patients with non-cancer pain or pain-related diagnosis are prescribed opioids. Okay, 2007 to 2012, the rate of opioid prescription has steadily increased. And now just recently, when you're hearing in the news, we are seeing how this trend is trying to be reversed. But notice how long it has taken for us now as individual states and through the federal government starting to try and curb the use and curb the abuse trends through some new legislation and new rules on how these drugs are being prescribed. But the prescribing rates for pain medicine, so again, those opioids in general, 49%, surgery, 37%, physical medication and rehabilitation, 36%. Half of the opioid pain relievers dispensed from primary caregivers. That's, a significant number. And so it's getting worse. And I'm not going to go through these in general because I think you've got a sense. But the one that I want to point out is that the number of prescription for opioids, hydrocodone, oxycodone, and the like, has changed from 76 million in 91 to 207 million prescriptions in 2013. Now, what that third bullet is doing here is important. So we've seen in 2015 this really fast spreading outbreak in HIV in a small area of southeastern Indiana, where 184 cases were reported. So what we're going to talk about a little bit is that the use of these prescription drugs spurned the addiction. However, then it started to get a little bit more difficult, right? In about 5 years ago, the U.S. started to talk a lot about prescription drug abuse, a lot about the sale of prescription drugs on the black market for illegal purposes, where a single oxycodone pill costs upwards of $50, $60, $70, $80. And so then what we saw was heroin come back into play. So we talked about heroin not being legally prescribed, but it's obviously been illegally created and sold in the United States for years. So what we saw is the purity of heroin increasing pretty dramatically. And then we saw people who generally, where we would not think of, sort of the white-collar suburban worker using heroin, it became so much cheaper than the prescription drugs, and they already had an addiction. And so we saw statistics like that one in the third bullet of HIV cases increasing because these people who started their addiction popping pills that they were getting from their doctors, then moved to buying those pills on the street, no longer had the funds or the availability to get those, and so they moved into the use of heroin. And with heroin came injections, and with that we saw things like the HIV epidemic, or the HIV outbreak in 2015. And so this not only has significant impact on us from the use and abuse, and we know what the costs of those are, we see these off-spur issues that people are sometimes not thinking about the impact from a community standpoint, from a workplace standpoint. And again, you need to think about that as an HR person or a safety person. You need to think about it not only just, how is the use of heroin going to impact your workers in the workplace. You need to think about how are things like that, an outbreak of HIV that we haven't seen in years, going to impact your bottom line as we see it impact healthcare costs. And so all of these things have, a primary impact. And then they have a secondary impact as an employer looks at what are the costs of those things going to be for you. This slide shows that it is significant in every state, and it is significant most for the United States. This does happen around the world, but it is happening significantly in the United States. And if you look at that very bottom box, the dark purple, that number is terrifying to me. So that is 96 to 143 prescriptions per year per 100 people. So 1-to-1 opioid prescriptions per person in those states. And those are some of the states where we're seeing the biggest overdose statistics now. But if you look at the ones in yellow, which are our best states, you're still talking about 5 in 10 or 7 in 10 people have been prescribed an opioid in that state. And so this is not something that is not readily available. And what we see is that the sources of the prescription drugs are not just being prescribed, right? So they're prescribed by physicians. Now, these are the people who are non-medical users, right? So these are the people who are saying, I am abusing or using it, but I was not prescribed. I was not the primary person for whom this opioid was prescribed. So they're being given by a friend or relative. Again, you've got someone at your house, you've got that old Tylenol with codeine in it, and they say they need to use it, and you let them, quote unquote, borrow, which is illegal. But it happens, obviously, if you look at this, very, very often. They're given it by a physician, a friend, and that's a very insignificant number, but important number to know. Stolen from a friend or relative, it's bought from a friend or relative, or it's bought from a drug dealer or a stranger, or there's, that other category. So it's important to know that this is not just like the other category where it's fake prescriptions or stolen from a doctor's office or a clinic or a hospital. This is really the way in which these drugs are being distributed, and it's very often family members allowing those drugs to be used by friends or non-prescribed family members. I heard a recent statistic about the hospitality industry attracting drug users. And again, it is that stolen from a friend or a relative, but it's stolen from a hotel room, right, where you have your prescription drugs and someone who has access to the room goes in. And they don't take the whole bottle, right? They take 2 or 4 or 5. And so often that goes unnoticed, and you don't realize where that drug has gone. And that, again, is another thing when your community, your city, your town has a prescription drug take back. Those are the things they're trying to prevent. They're trying to prevent non-prescribed users from going into your medicine chest and just taking 1 or 2, so that simply you don't recognize, if you have young kids or teenagers in your house, that they are being taken and being abused without your knowledge. So all of this sort of tells us how significant we see the problem, and then we see what tends to be more sensationalized, but it isn't, right? I'm not saying that to underestimate how significant it is when someone dies by an overdose. It tends to be talked about more because it's sort of, a sensational story. It's a very tragic story if it happens to a friend or a family member. But it's all brought about because of those statistics we've covered in the earlier slides. So common prescription opioids, both heroin and fentanyl, those are the drug overdose deaths, and they are massive. Every city, every town now is talking about how significant. In Philadelphia, which is the largest city next to me, the overdose drug deaths have, for the first time, surpassed homicide drug deaths in this city. So it is significant, and we're seeing it more and more. Hopefully it hasn't happened in your workplace. So what are some of the things we're starting to see that we are changing the trend? I'm going to mention one of the very first ones because it actually went into effect just the other day. So on October 1st, 2017, and I see I have an error on this slide, it should say 2017, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, announced that they are revising the Department of Health and Human Services mandatory guidelines for federal workplace drug testing programs. Now, a mandatory guideline by SAMHSA does not require that federal workplaces take the or expand their panel to include the testing of these additional Schedule II prescriptions. However, it allows them to. And so we expect that many federal workplaces and federal contractors are going to allow the testing now in their workplaces for these prescriptions like hydrocodone, hydromorphone, oxycodone, and oxymorphone. And then the DOT on that same day, which was January 23rd, 2017, issued what's called an NPRM, a Notice of Proposed Rulemaking. And with that, they are starting to align with the new HHS guidelines that will allow for the change in language from opiate to opioids, and then allow for the testing of these synthetic opioids. So we've not seen that. We're expecting that it will come any minute. And we don't know exactly how it will align. But when the DOT does that, you will see a change to that panel. And it will not be likely that's like the federal government where you may allow the testing. It will likely change the panel for all DOT employers. So it is important for those of you who are on the phone who have a significant population of DOT employees to notice that that will take place likely in 2018. And so it's important to note that when that occurs, your costs are likely going to change and your program's likely going to change. And so understand that that's coming. If you're planning for next year, plan for it. Unfortunately, we do not know any of the details of what that'll be, but you really want to put it on your horizons sort of roadmap that we know it is coming, and we'll see that change. But it also means that we're going to start to look at prescription drug use and abuse in the workplace in a different way. So, first you want to know that as an HR or a safety professional, you want to know what the signs of use and abuse are, right? So this slide shows what some of the signs of abuse are. It's important to know that when you're thinking about drug use from a workplace setting, that you not only want to know the signs of abuse, you want to be able to document them, and you want a resource to help you confirm what they are, because these signs can be produced by other issues, right? So medical issues, drowsiness, lethargy, paranoia, respiratory depression, nausea. Those can come about by different ways. Opiates have what is very, very commonly known as pinpoint or pinprick pupils. And so that is one sign that people often say is easier to tell. It's very hard to disguise it unless people are wearing dark sunglasses. But if you can look at their eyes, you can often see that the relaxed irises create that pinpoint. So what's important is that you know the signs. What's more important is that you train your supervisors, your managers for the signs, and that they are documenting it, that they are making note, and if they need to, using their medical review officer, using any medical personnel at their screening company, working to find out what you do in terms of how to document that, and to make sure that they are applying sort of the recognition of the signs of use and abuse across the employment body in the same way. What you don't want to do is find yourself having somebody with a medical issue and you're accusing them of a drug issue. You really just want to look at what the signs are. So you want to think about use, abuse, and addiction, right? They're talked about in the same way, but they're not the same thing. However, when we're talking about workplace prescription drug use, they all sort of run into one another. So many people can legally use prescribed drugs and not cross the line into abuse and addiction. I've been prescribed these in my past, had 4 kids, had dental work, any of those things, and had these drugs, used to manage the issue I had. And then I luckily didn't cross the line into abuse and addiction, but it's a very fine line. And so lots of people themselves, and any of you who've had addiction in your family, any of you who dealt with addiction in the workplace, knows what this is like. But very often the person who is abusing the drug does not recognize that they've crossed that line between use and addiction until the spiral has really gone downhill. So what are some signs that you can be looking for, either in a friend, a family, or in a worker, that may be a sign that the use has crossed over into an addiction? Besides those things we've talked to Kate that we talked about in the previous slide that indicate physical signs of abuse, think about some of the signs you look for in the workplace, right? Missing work, being frequently late for school or for other things, issues with job performance. And again, as this happens from use to abuse, you can see this getting super significant very quickly. Neglecting social and family obligations, the ability to stop becoming more difficult. And sometimes that's something no one knows about but the user, him or herself, right? We don't even know that they are using, and they're already making attempts because they're saying, okay, my prescription is running out sooner, I'm taking more than I should, or I'm starting to find myself obtaining these drugs in a way that is not legal. And so that is an important piece of it, but very often one that we don't know. And then it goes from a voluntary choice to becoming a psychological, and sometimes, and very often when there's an addiction issue, a physical need. And so again, most of you have heard or seen or are aware of the signs of withdrawal, and they're significant. So now we're going to switch focus, and I think we've pretty well established, without anyone being able to say, no, I think they're sort of making this up, right? We've fairly well established what the significant impact of prescription drug use is. Now let's start to switch focus and talk about prescription workplace prescription use. We are going to rely a bit on some of the National Safety Council's published results, and these are very up-to-date, 2017 survey. And when they talked to 500 HR decision makers in U.S. organizations with 50 or more employees, they found that the problem is significant and it's impacting the workplace. So again, I don't know those of you who are on today's call if you've got 50 employees, if you've got 10, or if you've got 5,000, but look at these percentages and do the application of these percentages to your own workplace and see if you're at trend, if you are above trend or below trend. But very likely you're seeing the impact of some of this in your workplace, whether or not you've attributed it to the use of prescription drug use. So some of you have experienced overdoses in the workplaces. Some of you have experienced the arrests, right, 10% arrests on or off the job. We recently had a client come to us just this week who has an FAA workforce, and they were notified of someone, now this isn't prescription drug use, right, but they were notified that this person had one of their FAA employees, not a pilot or an airman, thankfully, or an air traffic controller, but had gone to jail for a DUI over the weekend. And so that was significant not only in the loss of work, but well, what do I do about that? Like, what do I do if I think this person is then on the workplace driving a vehicle around our plant? What do I do? So arrests on and off the job impact that workplace. Borrowing or selling prescription drugs at work. If you're an HR professional on the phone, how would you handle that, right? How do you deal with that from a policy perspective? Near miss or injury on the workplace, complaints to negative impact on an employee, so complaints to the management staff, the negative impact on employee morale. I've had employees over the year, and I think that is one of the most under-talked about issues, not the drug use for the employee, but the impact to the productivity and the morale of the overall team. You know, I wonder if when John comes to work late, I wonder if, are they disciplining him? How come I'm having to pick up the additional workload? I know there's a problem. We know there's a problem. What are you doing about it, company? So then think about the family member of an employee who's affected, right? When something is going wrong, when someone is dealing with an issue of addiction in their family, how significant is that impact on workplace productivity? Then we see the ones that are just more blatant, right? Impaired or decreased job performance, a positive drug test, employee use of prescription pain relievers at work, and then absenteeism. And those are significant. For those of you who are dealing with those issues brought about, right? Sometimes someone is absent significantly, and then you start to have to deal with paying the other employees overtime to cover those shifts because you do not have a workforce that is flexible enough to handle people being absent regularly. And so you got to look at all of those different issues and see how they impact you. And very often what people talk about is that being a soft cost, right? Soft or hard, it's a cost, and it impacts your bottom line. What we also see are hard costs, right? So you see the increased workplace incidents, you see that, and you say, okay, when we see incidents or accidents at workplace, in our workplace, we're getting increased workers' compensation costs. So not only are you paying more claims, when workers are prescribed just one opioid, their average total claim cost is 3 times greater than claimants with similar claims who didn't get opioids. So again, where are all these impacts? Well, it's not just that you are having to deal with the issues of abuse in the workplace. You're dealing with things that opioids are expensive as they're prescribed, and so that impacts your health care costs. You're seeing increased workers' comp claims and costs and the effects to premium. You're seeing increased length of workers' comp and disability claims, and then increased lost work time. And so it is impactful to all of you. What we do know is that 57% of employers perform drug testing on employees, right? So there are 2 things that are significant about this number, and this isn't just as it impacts prescription drug use, it's your entire program. Those of you who are not testing, period, should be. There is what is called simply the runoff effect, right? So small employers often get the brunt of this. They aren't doing drug testing, they aren't doing background checks, and so those people who have something to hide, who don't want to be drug tested, tend to look to and rely on the employers who are doing no drug testing for employment. What we do see for those employers who do drug test is that they're doing what we call the standard 5-drug panel. Now, will that change when DOT changes? Will we stop to think about it as a standard panel because so many employers follow that panel as their ruler? We may, but when you look at what's in the standard drug panel, it is marijuana, cocaine, opiates, but again, that's codeine, morphine, not those synthetic opioids, hydrocodone, hydromorphone, amphetamines, and then PCP. When you look at a broader panel, we see people adding synthetic opioids, barbiturates, methadone, which is always a bit mind-boggling to me because methadone has not been produced in the United States in years. And actually, we looked at data from Quest Diagnostics just last week in preparing for one of our trainings and found that they have not had a single positive for methaqualone since 2009. We didn't go back further. Had we gone back further, we may have found out it was even longer. So that is one that is included, but really doesn't need to be included in the drug panel very much anymore, based on the percentage of positives we see, which is 0 at the moment. Benzodiazepines, these are an underlooked but an abused class of drugs. That's when you think about Xanax and Valium, Ativan. Methadone, and then propoxyphene, and then unsure, right? So some people just don't know what they're testing for in the panel. But we still see the drugs at the top of that slide tested for. We're seeing things like synthetic opioids and barbiturates being tested more and more often. And that is simply because employers are feeling the impact of them and starting to add them into their panels in a very purposeful way. We're going to move now, when we start to talk about workplace, into what can you do. So those of you who do drug testing in your workplace now know that generally the process goes that you do a screen, right? So you collect a specimen. It can be a hair test. It can be a urine test. It can be an oral fluid sample. But you collect the sample and you send it to the lab. Some of you are using instant testing technology. I hope that if you are doing that and you're using an instant cup, that you're using a reputable one, that you're using one that can show that it does actually detect drug use. And why that's important is if you are not, you open yourself up by not testing or by using a product that is really just the dog and pony, right? You're just doing it because you're under contract and you tell somebody that you do drug testing. If you're using a product that really does not do a good job in detecting the drugs you're testing for, you can open yourself up for negligent hiring and negligent employment suits. So it's important to use a reputable product. But either way, it should be screened for all of the drugs in the panel, and then it should move on for a confirmation drug test at the lab. No one should be taking employment action without a confirmation drug test. You're just, again, opening yourself up for tremendous risk of lawsuits. Once it is tested, it goes generally to a medical review. Now, for DOT programs, that's required. For many states, for both their voluntary and mandatory work laws, it's required to use a medical review. For everybody else where it's not required, it is best practice. And so what a medical review office does is they talk to the employee or the candidate who is test positive, and they see if they have a prescription drug. Now, when we're talking about use and abuse, and remember those slides, I didn't go over them just for fun, right? I went over those slides to remember how significant and where people are getting their drugs. So the MRO does a medical review and says, hey, Nina, I understand that you tested positive for morphine and codeine. Can you tell me, do you have a prescription drug use? Have you had recent surgery or hospitalization or gone to the doctor? And I'd say, yeah, I had a wisdom tooth pulled. I have a prescription for Tylenol 3 with codeine. And they would say, okay, let's get a copy of that prescription. Let's verify it. And if they verify it, then they're going to do what we call a reversal. They're going to reverse it. And they're going to go to you as an employer, and they're going to say this person is okay to hire, unless that person is performing a safety-sensitive job, right? Now, notice the loopholes in that, people, right? Notice the loopholes. So if I just had one prescription for one pill every 1 year, then the medical review officer would not know that I'm abusing the drug, that I'm using it outside of how it was prescribed. It is important to note that workplace drug testing, in the ways we're talking about it here, pre-employment, post-accident, reasonable suspicion, for cause, random, is not looking at therapeutic doses of that drug and determining whether it is being abused, right? And so liken it to sort of a pregnancy test. It doesn't tell you how pregnant you are. It just tells you that you are or you are not pregnant. It doesn't diagnose if it's new, and it doesn't diagnose if it's triplets, and it doesn't diagnose if you're near to the end or if you just found yourself pregnant. It just tells you that you are or you're not. And that is how workplace drug testing is. And so what you want to do is you want to think about the jobs in your workplace that are safety sensitive. Lots of them are defined here, right? So think about it. You're thinking about the line of production staff, drivers, DOT covered employees. What I want you to do is switch that logic and think about all of the other people in your workplace who are safety sensitive, right? So under OSHA, you've got OSHA compliance. You need to maintain people's safety. If you're not testing, or if you're not testing for a good panel or using a good device, then you're open again for those negligent hiring and those negligent employment actions. But think about safety sensitive from a different perspective, because that is the challenge of prescription drugs. It is really difficult to identify when a person's abusing a drug if they have a prescription for it. But people who are using these drugs because of the effects of them, think about what we talked about, right? Drowsiness, impaired cognition. Those issues can have an effect on your job performance. Safety sensitive in this case, and the definition of safety sensitive is critical. And so you're generally not allowed to inquire about the prescription medications. But when you look at what we're talking about today, a prescription drug testing program and a drug disclosure program, you are allowed to look at the impact of prescription drug use in your workplace. And when it is permissible by a job-related necessity and when it's consistent with a business necessity. So when we look back at that last slide and we talked about, those physical labor, or I guess it was a few slides ago, sorry, these physical labor jobs, right? The motor vehicle, the modes of transportation. I want you to be thinking about the other impact to safety and the use of prescription drugs for employers and looking at how you can think about it in terms of a different safety sensitive position. So safety sensitive in your workplace may mean they have access to private information. It may mean that they are healthcare providers. It may mean that they have access to the public, to credit cards. It could mean that they have responsibility for small children, minors, right? Anyone in healthcare, this is a simple one, so we're going to use that as a definition. But if they have access and they're providing care to people, then you could easily use what's called a legal definition of safety sensitive. And you want to make sure that when you develop a policy that you're using a legal definition of safety sensitive, no matter what it is. So if it is a developer in your office and they have access to information or they're programming into a program that could be a huge data breach in the country. We hear that all the time now in the news. They may be safety sensitive, right? So you want to make sure, look at this slide, you want to make sure that you have appropriate processes and policies in place and that you've got the procedures in place in your workplace, and many of you do not. So if you're going to look at using a drug deterrence program or a drug disclosure program, you first have to make sure that your appropriate policies are in place, that your job descriptions define in a legal definition safety sensitive, that you've got appropriate processes and work so that you can deal with the workers. What are you going to do, right? Once you identify somebody has a prescription drug use or abuse program issue, what are you going to do? And then making sure that your managers and supervisors are trained not with just identification, but what are the policies and procedures that are used. Those are very often the places where lawsuits come in, the policy issues, the appropriate application of the policy, not that you don't have it. 81% of policies are incomplete, and they don't adequately, and 67% don't adequately address the employee prescription use and abuse situation. So you want to look at that and you want to make sure that your policies, we're not going to talk about it, but look at last but not least on this slide, right? Use of medical marijuana. We're going to talk about a tiny bit perhaps if we have time, but you want to look at all of these different things, performance improvement plans, how would you keep people in the workplace when they have a drug use problem? How would you have return to work policies in place? All of those things are important, and they're places where people are not ready. So you want to start with a clearly written policy, and you want to say that an expanded panel can be used on the whole employee body, or that it can be used in a subset, depending if you're just going to use an expanded panel and these prescription opioids for a certain subset. And that can only be done if you've identified in your policy why that subset is going to be subjected to a different drug panel. You can, however, if you're doing random drug testing in your workplace, opt to also randomly select the panel, right? So that employees can know that they may get randomly selected to do a 5-drug panel, but they also may get drug tested to do a large expanded panel, and that's okay. You want to clearly identify the safety-sensitive positions, and that has to be done by definition of safety-sensitive, a legal definition, and then a position description. That's really important. You want to include a medical prescription disclosure policy in your policy if you're thinking of doing this right. And so what that does is say, for the prescriptions that have impairing effects, we are going to create job descriptions, and we're going to notify the employees in those safety-sensitive jobs that they have an obligation to disclose to us if they are on one of these drugs, whether legally or illegally. Now, obviously, the probability of showing you that illegally is going to be slimmer. However, take the case I said where I'm going to get a tooth pulled, and I'm in a safety-sensitive position. Really what would happen is I would take the job description I have that identifies my job as safety sensitive into my prescribing physician, not to my HR manager, but I'm going to take my job description and a form that's created and provided to me by my employer into my prescribing physician and say, here's the job I do. Here's a form. Can you fill out this form that I can take back to my employer and say, I am taking a job that can have an impairing effect, but that you can prescribe it and it will not impair me at the workplace. If they cannot, then there's 2 different avenues, right? They can work with me to take an alternate prescription that will allow me to perform my job function, or they can say that it cannot be used for that period of time, or I cannot do my job during that period of time on which I'm on that drug. And then as an HR manager, you're going to get into a different sort of discussion, right? You do not want to know why I'm on the drug. That's not what you're looking for. You're not even looking for what the specific drug is, but you're looking that I can or cannot perform the safety-sensitive duties that I am employed by you to perform. And then you can start into an iterative process with that employee and say, hey, look, I can't do my job while I'm on this. Can you, this drug, can you accommodate? And my doctor said there's no other alternative, right? So can you accommodate me? If I'm a nurse who's going out and doing field medical procedures, can I do office work? And is that okay, right? If I am driving a forklift, can I not? Can I not perform that physical labor? If I can't be accommodated by the workplace, then you want to look into leave, right? Can I take short-term disability, long-term disability? Do I have PTO that I can use? And finally, if it cannot be accommodated, period, and the person has no options to take leave, then you can look at not hiring or terminating the employment of that person. So I covered that quickly. It's important to understand the details of what the policy is, that the policy focuses on drug classes. You don't want to just put brand names in there. It needs to clearly define that process, right? So what are the consequences? What is different about this is drug detection is not generally what we see as termination offense in these cases. What we see, the non-disclosure. So if someone does not disclose and you do a random drug test on the person or you do a reasonable cause, then you don't actually have to terminate their employment based on the positive drug test. You can terminate their employment based on the policy violation because they did not disclose to you and their prescribing physician that they were in this safety-sensitive role. And so it's a policy violation. So you want to make sure that you're defining the illegal use of the prescription drugs, but you also want to make sure that you are saying what the violation of the non-disclosure or the positive drug test causes in terms of an employment action against them. And so it's the employee's responsibility, not yours, to use the personnel procedures that you've put in place so that they avoid the unsafe workplace policies and practices. So you want to define those safety-sensitive rules. You want to implement a prescription drug disclosure program for those safety-sensitive positions. You want to define what the expanded lab panel is and include those prescription drugs. You need to update the testing policy. You need to communicate that to everybody. And then that one last piece is we say contract with an MRO or an occupational health doctor because as an HR or a safety person, generally you do not want to know the details of the ailment or the prescription. And so if the prescribing physician has questions regarding the job description or the policy you have in place, you do generally want to have someone who has a medical background to be able to act as your contracted liaison with those prescribing physicians when employees avail themselves on the drug disclosure program. You want to do employee education, right? So anytime you issue a new policy, you want to give people warning. You want to describe what's happening. You want to describe why it's happening. It does not need to be a punitive situation. Think back to those slides we discussed about people and morale. If they're being impacted by abuse and drug use in the workplace, then it's very likely that they are going to be concerned. So you want to train them about why and what their obligation is to report prescription drug use in their workplace. You want to address the issue, right? So update the policy, train the employees and the supervisors on the policy signs, the use. You want to use that contracted MRO and explain to them how that person is going to be used, them meaning your managers. And then you want to create that form we talked about, which is the treating physician employer form that shows the job description. And you have to explain to employees that they need to go and take that. You also need to explain to managers, because this very often happens in the supervisor education program, that they do not want to discuss it with the employee, right? They want to say, go to your prescription, take your job description, go to your physician, take your job description, take the form and have it filled out. They do not want to be collecting information on what ailment the person has, what they're undergoing treatment for. They want to just know what the policy is, how to apply it, when they can do post-accident reasonable suspicion drug testing, what the signs and symptoms are, and so you want to provide that type of education. They want to document, and follow the procedures. And so if nothing else they come out of those educational trainings with, they want to know, oh my gosh, if this comes up, I want to go to HR so I can make sure I follow the policies correctly and I document correctly. And then what they do, right, if someone starts to disclose to them about a disability or medical condition, they really want to know that they can go to HR and they have policies and procedures to follow, or they can start to look them up with assistance from HR in their company policy and their procedural handbooks. We also recommend employee assistance because, again, when you think about the extraordinary nature of this issue and the problem and the impact for employers, you want to look at, is there a way to keep these employees in your workplace, right? Can you provide an EAP program? Can you have a substance abuse professional contracted within your employer or through your employer so that you can look at ways, if someone does not disclose, is it a last chance circumstance? Can you keep them in the workplace? And then what do you do if you have an ADA claim? So you don't always want to say this is a one and done situation. You pay a lot and turnover costs a lot. There are a lot of valuable long-term employees who have these issues. And so you want to look at ways that you can do treatment and that you can return good employees to work. And you also want to be cognizant that recovery, now in the ADA it specifically lists alcohol, but we generally say it's going to apply to drug addiction as well. So once someone is recovered, they are covered under the ADA. And so it's important to understand that in all of these cases you have to look at, is a reasonable accommodation applicable, and then you want to apply it. And if it's not, you want to go back to that idea of document, document, document. And then drug testing, right? You want to look at when it's appropriate to drug test, when a standard panel is going to be used, and you have to understand that a 5 panel does not detect many of these prescription drugs we talked about today. We always recommend using a SAMHSA-approved laboratory and an MRO, and we talked about that. And you have to understand that the laws vary by state. Some have union agreements. Some states have mandatory drug testing just for a certain industry. Some have voluntary laws. So it's important to understand all of those laws in your state and then develop a policy for fitness for duty for return to work and use that standard legal language to define those safety-sensitive positions and when testing is appropriate. And so with that, we are at the top of the hour. We don't have time for many questions, but if we have 1 or 2 and people want to stay on, we can certainly take those. If not, we're going to end with how to contact Orange Tree Screening, who put on today's webinar with the important information about prescription drug use and how you can apply the use and deter the use of drug use in your workforce. And so with that, Suzanne, I'll turn over.
Okay, perfect. Thank you so much, Nina. I do see a couple hands raised, so I will just a reminder that if you do have a question, Nina will be on to answer your question. Please raise your hand within GoToWebinar. Carolyn Botker, I am going to unmute you so you can ask your question.
Carolyn, do you have a question?
Okay.
If you have a question and you didn't have a chance to ask it today, you can submit it as well, and we can respond after the webinar today.
Okay, I'm seeing one other hand raised. Melanie, I'll unmute you. Do you have a question, Melanie?
I don't think I have a microphone.
Oh, we can hear you.
Oh, yeah, no, we can hear you.
Oh, okay. Well, I wasn't sure about my question was, would we have access to these slides? I'd like to share them.
Yep, we will make them available after the presentation. You'll receive an email with a link to obtain them.
Thank you.
We did have a question submitted in advance, Nina. I'll just ask you. Someone asked, how do we go about reviewing our corporate drug testing program and policies, and how often should we be doing that?
Well, if you feel confident, you can certainly look at reviewing your policy. If you would like to have your policy rewritten or reviewed, you can contact that info@otes.com, and they can work with you to get a policy written. CCG, we do policies, hundreds of them all the time. If you have not had your policy reviewed in a year, you need to have your policy reviewed. There were upwards of 50 laws passed that impacted drug testing and drug abuse in the workplace. And so it's really important that you do it annually and have it reviewed for every single state in which you do business. And so you can contact Orange Tree and they can talk to you about that if you haven't had it done in a year. Pretty critical. I can guarantee you need to look at it if you haven't reviewed it in the past year.
Okay, and then we had another question submitted. Would an in-home child care worker be considered a safety-sensitive position? Would it depend on the ages of the child cared for or broadly include any child under the care of the employee?
Again, that's another question that would depend specifically on that, the state in which the person is doing it. However, when you're looking at a classic example of somebody that you could define and a role that you could define as safety sensitive, that would be one. And so as an employer of those people, it would be really important to get a legal definition. Anyone who has access to children and who are doing any sort of medical, it's a fairly easy definition of safety sensitive that you can do from a legal perspective and put in place with those people. But check your state laws. You may be required under the state law to do it.
Okay, and then the final question, unless we have another hand raised, is does medical marijuana count as prescription drugs in the U.S. where it is legal?
Medical marijuana, it's really important to look at your state. Medical marijuana, period, is a Schedule I drug in the United States, so it cannot be prescribed legally, even if the state says it is. However, we've seen 3 states recently where there are rulings against employers, and they do have to do things like invoke this, the iterative process around accommodations being made, even though it's a Schedule I drug. So it's a misnomer. There is no prescription in the United States for marijuana because marijuana is not legal to be prescribed. However, as we're seeing those laws passed, and it is medicinally legal in 29 states, it is critical that you understand what you can and can't do with prescription and recreational marijuana, and your policy should specifically state that, and you should be training your employers and your supervisors, or your employees and supervisors, on what your rules are in your policy for marijuana, both recreational and medical.
Okay. Well, I don't see any other hands raised, so thank you so much, Nina, for your time and your very interesting presentation. We appreciate you being on the call today. And
thank you for having me.
Okay. And we'll send a follow-up email with the link to the slides. Any questions, you can send them along, info@otes.com. We can loop you in with Nina if you have additional questions for her as well. But thank you, everyone, for joining, and thanks so much, Nina.
Thank you. Bye-bye.
Bye-bye.